Hi, I'm Dr. B.B. Lee for George Washington University in Washington, D.C. Today, the title of my topic to deliver to you is Clinical and History Assessment for the Lymphedema and Lipedema. The target audience for this topic is a vein and lymphatic expert. Indeed, the vein and lymphatic expert should know and should report in the clinical chart when visiting a patient with suspected or with certain lymphedema or lipedema. Indeed, many laymen, the lymphedema doesn't need a test for a diagnosis since no one can overlook such swollen limb. But regretfully, it is not true by any sense. Lymphedema and lipedema are a typical example to confuse the clinicians. They are as different as an apple and orange, though they look extremely similar to each other. Besides, there are so many cases with limb swelling caused by garden variety of local, regional, and systemic cause other than the lymphedema origin. Systemic causes for the limb swelling represent, for example, cardiac failure, hepatic failure, renal failure, thyroid failure, idiopathic cyclic edema, and of course, infamous drug-causing edema as well. Further, there are so many different conditions with regional or local cause, like venous origin for chronic venous insufficiency, also lymphatic origin for the chronic lymphedema, beside mixed condition like flebbolymphedema, as well as congenital vascular malformation, lipedema, factitious edema, etc. But all these confusing causes of background can be easily identified in its majority through a thorough clinical and history assessment if the clinician should remain vigilant to look for these basic conditions for the differential diagnosis of swollen limb. Hence, the first step for correct diagnosis of the chronic lymphedema, either primary or secondary, should go through these items of systemic, regional, and local causes one by one with proper recording. The differential diagnosis between the lymphedema and the lipedema will come next, with further careful examination on the distribution of the swelling. Indeed, this is the many different cases of lymphedema, either primary or secondary as well. And this is a lipedema. Please look at the ankle area to be sure. As you see, the swelling was stopped right at the ankle level, and the foot and toes are saved from lymphedematous swelling. Indeed, lipedema does not accompany the swelling below the ankle, saving the foot from the swelling, on contrary to the lymphedema, with often stemmer signs you are familiar with, until the last, when the secondary lymphedema should develop as its complication of the lipedema. Such careful history and physical examination could provide most of crucial information or clues for the differential diagnosis, and no particular tests are needed to confirm its clinical diagnosis. Indeed, this unique distribution of the fat, the tissue of swelling along the ankle is more than enough in its majority. A thorough documentation of these findings, observed through careful history and physical exam, are crucial for precise assessment of the progress of disease, beside the response to treatment and the patient compliance. It should remain as the baseline to compare with further periodically re-examination findings to provide crucial clinical laboratory staging of the disease. Such aggressive and repeated assessment of clinical condition should include subclinical infection in early and latent stage of lymphedema in particular, and also rule out combined venous disease as crucial predisposing factors. Thank you for your attention.